unfortunately, it will maybe not be recorded. Oh, it's recording at last. So this is the program where we're going through. We'll start with the yellow fever update, and that's probably the most heavy part. And it's actually a proposition, so you can give me feedback or send it afterwards, whatever you feel. Then we'll go quickly to a new malaria map, some updates in Zika, or, well, where are we now? Measles, polio, some practical issues, and then Patrick is going to talk a bit about rabies, post-exposure prophylaxis. So, as you all know, last year there was a new guideline from the WHO who said that from the 11th of July 2016, revaccination or booster doses or of yellow fever vaccine could not be required anymore of international travelers as a condition of entry into another country. This was already planned since a long time, 2 years before, but since last year, so it's a bit more than a year ago, it was really, it became the law. And they said that no new certificates were needed, but they stated as well that countries and healthcare providers are still free to make requirements on vaccination or revaccination for their own population. So actually stating that every country is still free to be more demanding for their own travelers. But they issued no guidelines about that. So they did not say anything specific about eventual suboptimal protection in certain subpopulations or recommended booster injections. So as a result of that, each country made its own guidelines. On what was this decision based? It was actually based by a recommendation made by the SAGE, based on 10 studies done earlier on long-term immune response. But then last year, this article was published, questioning the same articles, but also adding another article which was not published at the time the WHO issued its new guidelines. And this article caused, well, quite some nervousness in people doing travel medicine. And so they are going through the literature again, but giving a quite different interpretation of the results and asking some specific questions. One of these questions is about the certification, the difference between endemic and non-endemic settings. So if they pulled the results, well, they found that generally in endemic settings, about 97% remain seropositive after 10 years. But the results seem to be very different in non-endemic settings, where they found seropositivity after 10 years of 83% only. Meaning that if we count on seropositivity as correlative protection, 1 out of 5 or 1 out of 6 loses its measurable antibodies after 10 years in non-endemic settings. Another question which was posed in that article is, how can we be sure that our traveler is protected? Is it only the measurement of antibodies? Or is there a role of memory T cells? And that was something the WHO was counting on. They actually thought that if there's not sufficient antibodies, there is a role of memory T cells, but it seems to be very unclear and certainly not proven. So it's certainly not sure that we can count of these memory T cells. Another question was the cutoff of neutralizing antibodies. Different cutoffs have been used, different models have been used, different techniques have been used. But in animal models, at least they found with the neutralizing antibodies of 10 or 20, they've seen breakthrough infections in animal models, which is not always the same as a human, of course. Another problem which is highlighted in this article is that in children, the seroconversion rate is even lower. In the group of children between 9 and 23 months, only 85% more or less is going through a seroconversion. And it is even lower if the children received measles vaccinations in the same period. And at last, if we take all these things in account, if we believe that these questions are true, then, well, do we see more breakthrough infections than were formerly reported? And the answer seems yes. So at the time the WHO was changing its recommendations, they counted only 12 breakthrough infections. The CDC made a slight upgrade and counted 18, plus 5 breakthrough infections within 10 days after vaccinations. But then this article was published, and it was published after the WHO recommendations. This is a retrospective study in Brazil, retrospective, so it has certainly its limitations, where they looked at the yellow fever cases they have seen between 1973 and 2008. And there they found that among those cases, 55% had a history of vaccination. We have no information about how these vaccines were administered or how they were stored, etc. But okay, it seems not very reassuring. And even in that same article, they stated 3% had been vaccinated within 10 years. With the limitations of all this evidence or all these observations, it's certainly not reassuring. So we were confronted with the question, well, okay, we have at one hand the WHO guidelines, which leaves quite an open door for being more demanding for certain categories of travelers. And on the other hand, these questions, this evidence or these observations that have been made. And so one way to handle all this was to look at our neighbors and see what other countries do with this information. So I'm going now through some examples of different recommendations, different countries, to show you what has been inspiring us in order to adapt our recommendations as well. So the CDC, the guidelines of United States, they recommend an additional dose of yellow fever for the pregnant, those after hematopoietic stem cell transplantation, and the HIV. But, and this is the full text, it's from a link of a link of a link, so it's not so clearly in the yellow book. But anyway, if you really want to go into detail, they write that a booster dose may be given to travelers who received their last dose of yellow fever vaccine at least 10 years previously and who will be at higher risk setting. Okay, and then they go further into detail based on season, location, activities, and duration of their travel. And to give an example, this would include travelers who plan to spend a prolonged time in an endemic region, or those traveling to highly endemic regions such as rural West Africa during peak transmission season or areas with an ongoing outbreak. Another category, but this was in our former guideline as well, is laboratory workers who routinely handle wild-type yellow fever virus. So this is an example. What do the Dutch do? Or what are they doing? They recommend revaccination once if the former vaccination was given during pregnancy, within an interval of 4 weeks between another vaccine, after stem cell transplantation, also in case of treatment with interferon. And then they recommend revaccination every 10 years in the HIV, labo workers, and they are going into more restrict. They're not including any more travelers to outbreak countries because it was too complicated to handle. UK, knock-knock, what do they? Well, they start very, vague, with a single dose correctly administered confers immunity in 95 to 100% of recipients. Data suggests that, with some exceptions, most vaccine recipients will obtain protective antibody titers for potentially several decades or possibly lifelong. But they talk also about reinforcing immunization. And again, they start with an introduction. They say that the WHO says that currently available data suggests that a single dose of yellow fever vaccine appears to confer lifelong protective immunity against yellow fever disease. Therefore, with some exceptions, there it starts, a booster dose of yellow fever vaccine is not needed to maintain immunity. And if you want to go into details, what do they mean with their exceptions? They talk about reinforcing immunization, but this is something which you have to look up in their green book, and that's a book with guidelines about vaccination. So they suggest to do reinforcing immunization for children below the age of 2 years who were vaccinated below the age of 2 years, in the pregnant, HIV, the immune suppressed, and those who were vaccinated before a bone marrow transplant, and in certain situations where there is concern about the traveler's risk of exposure to yellow fever. And then they give some examples, like working, living for an extended period in a high-risk setting. And then a booster dose of yellow fever vaccine can be considered. And to know whether yes or no, you have to seek advice by an expert. The French, they say, à ce qui concerne les voyageurs, donc they say boosters should be given to les enfants vaccinés avant l'âge de 2 ans, en cas de grossesse, les personnes avec le VIH et les immunodéprimés, et pour les personnes dont la vaccination contre la fièvre jaune date de plus de 10 ans, une seconde dose est recommandée en cas d'épidémie signalée dans le pays visité. Okay, according to WHO, epidemic means at least one case. And then the Swiss, they made it easier and, well, more easy to use at least. They say a first yellow fever vaccine and a single booster after 10 years in case of yellow fever re-exposure. So it's actually boosts everyone who is in ongoing risk area. That's probably the easiest way, but it's far away from the WHO recommendations. Okay, as well, a reminder, what did we say, what we did suggest last year, very close to what the other countries say, very close to the WHO recommendations. So that it's actually live and valid for everyone, except some exceptions. And in certain categories of travelers, it's just a booster before the next exposure. In children younger than 9 months old, in the pregnant, and those who were vaccinated within 28 days with 2 different live vaccines, measles and yellow fever, for example. We suggested a booster after 10 years or the testing of neutralizing antibodies in people with reduced immunity, like HIV due to medication or after a bone marrow transplantation, and then people with an increased risk, the laboratory employees, and those going to work in an outbreak. Okay. What is our suggestion now to adapt? It's this last category, mainly this last category. There's people with an increased risk, and to enlarge that category. And not only those people working in outbreaks, but, well, a huge gray zone. So this is our proposal based on, well, everything I just showed. For the children, to upgrade the age limit to 24 months, like what many other countries do, and because we're not sure that above that age they are really protected. But the main difference is here below, and I put it in red. In case of high risk of exposure to yellow fever, single booster, or as an alternative, but that's not very practical in daily routine, the testing of neutralizing antibodies should be considered after 10 years. And then we give some examples: laboratory workers, people staying for extended periods in endemic region, or traveling to a high-risk region, or there where there's an epidemic. So again, it's a huge gray zone, but we believe that on one hand we cannot go really far from the WHO recommendations, but on the other hand we have these questions, we have these new observations, which we cannot neglect either. And actually we're waiting until WHO is, maybe going more clear into certain recommendations about this groups. But in reality, what will probably happen, what we expect to happen, we know that anyway, many experts have a very low threshold to give a single booster if there is an ongoing risk of exposure to yellow fever. So for the immunocompetent, if they keep on going to West Africa, for example, we can consider to give once a booster after 10 years. And even that is disputed, but okay, only based on this single article from Brazil, where they've seen that sometimes the antibodies are decreasing very fast in certain people, They don't know exactly why, probably because the time of viremi is too short to have a long immunity. And then in the immunocompromised, where anyway we want to be sure that they're protected by boosting once or sometimes even more, if there's no contraindication, of course. What about administration then? Again, we're a bit squeezed between what we see, what we would like to do about what we can foresee for the future of our travelers, but also the WHO recommendations. So for the time being, we suggest that everything remains the same. So for many people, we still keep on putting this stamp or writing down lifelong, because that is what the WHO wants us to do in order that our travelers don't get any problems at the border. What we suggested for this category with temporary conditions, like the young children, the pregnant, and so on, we decided last year that we would put a validity of this certificate of a year in order to remind the traveler that he needs a booster, well, in daily life before the next exposure. And for the immunocompromised, we decided last year to put an end date of 10 years. But then we find, well, what shall we do about this high risk? Nobody knows, of course, not always, what the traveling is going to do in the next 10 or 20 years. Well, it's a question I'm asking to the audience as well, or maybe for afterwards to discuss what shall we do? I've made some examples to discuss with you, but maybe we can switch on the light again. I don't know where I can do that. But okay, I can see you, so you can maybe reply just to feel a bit how these things are working. So one example is a VFR going to Guinea for 4 weeks. And she was vaccinated in 2014 while pregnant. Well, shall we revaccinate, yes or no? Yeah. Okay, that's clear, I think. A child 2 years old, VFR as well, going to Nigeria for 1 month, and was vaccinated at the age of 10 months. Yeah, okay. And then a healthy businessman travels almost every 6 weeks to Central Africa, will stay for 5 days in Kinshasa, and that is a single yellow fever vaccine 11 years ago. No. Yeah. Okay. Then an expat traveling to Equateur in RDC had 2 vaccines previously in 1990 and 2002. Should we revaccinate? He had already 2 of the. Okay. And if he would go to, I don't know, let's say Sierra Leone, then is Sierra Leone not. Okay. If you are going to Cameroon, HIV positive with good control of his disease, and was vaccinated twice in 95 and 2005. Could see the 4 counts, but HIV positive. Maybe Charlotte. No. For the time being, for HIV, it's every 10 years. We don't know CD4 count at the beginning. Well. And then the researcher who is going to Brazil, to the Amazons, will spend 2 years and had a vaccine in 2005. Boost or not? I see many people nodding boost. Yeah, I think so with this new observations. Yes. It's, yeah. Yeah. But people are vaccinated there in the northern part normally. So I would say yes. While a year ago I would say no. Yeah. And then another last example, another traveler spending 6 months in South America, going to cross several countries, and had 1 vaccine in 2005. This may be a most tricky question, which is discussable, I think. Yes or no? I think both are positive. No. Yes. Yeah. Remains vague, I know. But we know. Okay. Okay, maybe everyone can digest this a bit, but feedback is welcome, huh? Now or after the session. Yeah. Sorry? You can, if you have time. Eh? If he's leaving next week, you have no time. But otherwise, you can. Yeah.